Hello to the California Residency Network. This is Conrad Amenta at the California Academy of Family Physicians. And I have Dr. Walt Mills here with me from Natividad Family Medicine Residency Program. And Walt has kindly volunteered to take us through a perspective on faculty development, past, present, and future. And the purpose of this presentation for CRN members, as I'm sure you know, the CRN has set out 4 priority areas. Faculty development is one of them. And we at CAFP are always looking for ways to try and facilitate information sharing between the family medicine residency programs. Dr. Mills has been incredibly involved with the Academy over the years, and we benefit so much from his experience and from his insight. And he's volunteered to share that insight with us today. And so thank you very much, Dr. Mills. And without further ado, I will hand the presentation over to you.
Great. Well, thank you, Conrad. And hello to my friends in CRN. Conrad asked me to think a little bit about, where we've been in terms of family medicine faculty. And, we've got a 40, 50-year history, but we're going to kind of just focus on since the change of the millennium to now, and then just guessing forward a little bit together to help guide some of our thoughts about how the Academy and the California Residency Network specifically, how we can help one another navigate the challenges and opportunities that the future holds for us as knowledgeably as possible. The title, Past, Present, Future. We'll see how much we can learn in reflection about the past, acknowledge the present, and embrace the future together. So just thinking back to the turn of the century, the millennium, one of the big marks in terms of what's influenced us as faculty and as physicians and as citizens was the recognition that we did not have a high-performing healthcare delivery system. Really, the telling point was 99, 2000, 2001, when the Institute of Medicine called out the quality chasm and then started to talk about some of the solutions to us getting to a place where we could be providing safer, more high-quality care. And as academicians training the next generation, that was really the beginning of an incredible stretch, I think, for all of us as faculty, because we were raised, most of us at that point had been raised in the prior century that was being indicted as a place that was inadequate in terms of training and delivering care that we were proud of in terms of safety and quality. What do we say? 3 large airplanes were crashing every day in terms of numbers of patients that were dying due to medical care in the United States. Huge improvements since then. So what else happened about that time? The ACGME came out with its outcome project, in part generated by the Institute of Medicine and other requisites that said we needed to go from more of a process to an outcomes way of thinking about education. So that really drove a lot. Recall those faculty who were around in 2000, 2005, as we struggled to understand this competency-based education. All the faculty development programs attempted to understand how do we translate these 6 competencies that are called out in the slide there for us into actually curriculum and evaluation. We weren't sure what's professionalism. I think we still have many interesting dialogues about what does that really mean. Systems-based practice. We weren't trained in that in the prior century, and yet it was being called out as something that we were accountable for with our learners. Practice-based learning and improvement. How many faculty knew what a PDSA was back in the day, and on so forth. It was a beginning of us really challenging ourselves to the fact that to be a good faculty member meant more than just being a good clinician who could translate that into passing on through the apprentice model how to succeed in the 21st century as a high-performing family physician. What else was going on then? Well, next, the Future of Family Medicine project. Early 2000s came on the scene as a requirement, as a real calling for us to reimagine our specialty of family practice into family medicine. Recall, the American Board of Family Physicians became the American Board of Family Medicine. Many other things began to quickly change as we sought out a future way of defining how America could have 21st century primary care, leveraging the legacy of the personal physician, but then being able to adapt into the needs and requirements for our new world. And that's when the patient-centered medical home came on board. I can still recall early faculty development sessions where faculty would question, what was this PCMH piece of things? Recall, less than 20% of all residencies had electronic health records at that time. Now it's a given, right? We're into a whole other level of interesting change. So how about moving to the present? The ACGME came out with the next accreditation system requirements, which emphasize quality and safety. Certainly things that faculty at that point really had not had definitive training, experience, let alone skills that we could pass on to our learners. A big gap for all of us. Now that's changed to the ACGME's new accreditation system, and it's here. We used to call that the future. It is here with us as we think about where are we going next. Next slide. I think everybody on this call has probably by now, and if you haven't, you will soon, have your first, maybe your second or third clinical learning environment review visit from the ACGME. This is the beginning of an interesting way for us to think about playing roles as faculty. The Pursuing Excellence in Clinical Learning Environments calls out the 6 pathways to excellence. And right at the top, it's not medical knowledge. It's not even patient care. They don't really mention communication directly. They've gone beyond saying system-based practice is crucial. It is, of course, but it's translated into these 6 pathways to excellence. And I think as faculty, we can get excited about that. You know, who doesn't want to be excellent in terms of being able to be an institution proud to have excellent family physicians graduating and practicing? Patient safety, healthcare quality, care transition, supervision, fatigue management and mitigation, professionalism. Now here I'm just going to allude a little bit to the future. The new program and institution requirements that went live in July 2017, literally weeks ago. Some of you probably have seen them and started to talk about what that means for us as faculty. Well, in there you will see a lot of dedication to the importance of having discrete, organized, coherent programs for resident and faculty well-being. It talks about resiliency. It also talks about having our local systems, our local programs have viable well-being curriculum. So this couldn't arrive too soon. The other thing that's going to be called out for all of us is moving to understanding social determinants of health in even a higher level. Some of our programs around the state are leading the way, statewide and nationally, regarding the appreciation, insight, and organized delivery of teaching and caring for those in safety net populations where we really are having impact through population health and other community-oriented primary care on the social determinants of health. But in large part, the ACGME feels we're just at the beginning of this. And this will require us as faculty to help lead this cutting edge change. And this will be called out in the next CLEAR visits. Social determinants of health will be more prominent, as will well-being and resiliency. Next. So I don't want to really move into the future without addressing this. Across the board, there is an increasing recognition of the epidemic that we have in medicine of burnout. Our nurses, our other allied health professionals, all of our specialties, and family medicine is near the top in terms of the numbers that are being reported. As many as 2/3 of our family physicians report being at or near burnout at any one time. And what this particular graph here shows is a scoring of the Maslow burnout scales that all faculty should be familiar with, both in terms of helping those you're advising and teaching and supervising, but also in terms of our own self-care and designing programs internally that help us mitigate the risk of burnout. You'll see exhaustion, cynicism. When you hear residents talk about a faculty engaging them in a not so productive way at times, often it's because that faculty member is crispy, as we say, or burned out. So this will be a crucial part of faculty development in terms of being able to have the tools and skills and knowledge and attitudes to succeed as teachers of family medicine going into the future. Next. So let's go back to these ACGME competencies that have marked this century of academic development, faculty development. So certainly our forefathers and mothers would agree patient care and medical knowledge have always been the centerpieces of care and teaching. And we're all now engaged to a level of competency ourselves in terms of practice-based learning and improvement. Most of us have things going on with quality improvement, performance improvement. We've engaged in various IHI, Institute for Healthcare Improvement, or other performance improvement curricula for our residents and medical students. Certainly communication's always been a strong part of our relationship-centered specialty, both as teachers and as clinicians. We continue to learn how to do that better with how to understand how to have crucial conversations, how to negotiate conflict better, pushes us as we get to the next level of having high-performing teams. Professionalism is always at the core, and then approaching medicine as a system in all its many interesting ways is crucial. But what about our future competencies? Over to the far lower edge of that PowerPoint. Let's see. Next. Well, one of them is, it's been proposed that we have a 7th competency. Whether that actually gets formally indoctrinated into the way we think about GME. Remember, undergraduate medical education with all our medical students now, those are the 6 competencies that are held to in terms of medical school teaching and experience, as well as CME and beyond. Well, it's really felt the future largely holds us being able to know how to participate and appropriately lead interprofessional healthcare teams. So you can see these bullet points that call out some of the dimensions of being able to feel competent, participating effectively in interprofessional collaboration, where we need to know the roles and responsibilities of other healthcare professionals. Think about how Song Brown is calling that out for us, even as we as programs prepare to have our next application in for that grant. They're looking for how well are we teaching and participating with other learners on the healthcare professional team. You see on the very bottom, the idea of having a climate of mutual respect, integrity, and trust. I can't help but think in some of the advocacy work that we've done in the past, where we've been somewhat protective of the scope of practice, and more recently how the Academy has continued to lead the way in terms of how to embrace the other disciplines engaged in our mission of caring for our community. What about another potential competency that's around the corner? Next. I think with nearly half of all of the California medical student graduates that go into family medicine being osteopaths, it's incumbent upon us as the California Residency Network to understand how we're going to best leverage this change of going to a single accreditation system as osteopathic accreditation goes away and the ACGME becomes the home for all practicing family physicians in training in California and the United States. So how do allopathic MD preceptors knowledgeably, ethically, appropriately supervise and teach osteopathic family medicine residents? People have spent a fair amount of energy and effort, dedication to mastering the osteopathic principles and practice in medical school. Do they land in our residency programs and that's it? Are they encouraged to continue to grow and learn how to care for patients in the holistic way that osteopathy promotes? I think that is definitely a part of our future. How we figure out the resources and the allocations and our profiles as residencies will really determine a great deal how family medicine is practiced in 5 or 10 years when these graduates are starting to develop their own footprint in our communities. And the other bullet point here, the ACGME osteopathic recognition calls out for an even more organized way that programs can embrace osteopathy. It requires curriculum, it requires evaluation, it requires a certain amount of faculty. The ACGME is actually promoting this to a level that there is absolutely no fee for those who apply for osteopathic recognition. But for those faculty who may be listening to this webinar who have an interest, especially our DOs, I think it would be wise to get together and to understand how we can best make sure that during this particular inflection point, as we go to a single accreditation system, that we take opportunity to understand how we as faculty can support osteopathic principles and practice. I know that in our own residency, there are 4 of us who are going through an 18-month core faculty development program that is being sponsored by Thoreau Osteopathic Medical School. And the 4 allopaths, we're learning how to care for our own patients and how to teach and supervise our medical students and our residents in a much better way. And actually, the principles of faculty development, they translate into most of the domains of being a high-performing family medicine faculty member. You can let me know if you have an interest in figuring out what other resources your faculty may have for such development. Next. Let's go back here to the future. So in 2002, there was this call for us to, again, reinvent ourselves as a specialty, the Future of Family Medicine Project, which has driven much of the innovation and change that we now have in 2017. And then the Future of Family Medicine 2.0, now in 2 or 3 years of implementation, the Family Medicine for America's Health. We'll see. I'm sure there'll be a 3 and a 4 and a 5. And I think the point of this slide is that, as Heraclides said long ago, the only constant is change. So understanding how we as faculty can negotiate, lead, manage, change, and all the challenges and opportunities that those whitewaters offer us is a crucial part of any faculty development program. Next. So one of the pieces to call out is that there is this recognition, you'll see it called many things now, but there's a flood of information and research on just how do we best transform our clinical learning environments to meet the needs of the new 21st century family physician training. One of those is being able to understand how do we go beyond PCMH, because clearly patient-centered medical home accreditation has had some benefits, but many people feel that that's the house and not really the home. Often the quadruple aim, that fourth aim of physician or provider well-being, is not well addressed. It's more running on just different hamster wheels than the past. People feel troubled by a lot of this. And what's come up is there are other ways of thinking about this. The UCSF Center for Excellence in Primary Care published in the AAMC, and you'll see right there the alluded to internet site, High Functioning Primary Care Residency Clinics, the building blocks for providing excellent care and training. It's a roadmap that seems to be getting ever more evidence behind it in terms of how to most adroitly and effectively negotiate improving the experience of your residents and your faculty and your staff and your patients in resident teaching clinics. And it's laudable enough to get to be a high-performing primary care clinic offering great ambulatory care. It's far more interesting with all the moving parts of us part-time faculty and part-time residents, etc., to get to a place where we're proud and excited about being in our clinics offering care. It wasn't long ago that I was at a residency where a resident told me, I'd rather take call overnight than have to set foot in that clinic. Those days are largely gone as we embrace the fact that the majority of our graduates will spend most of their career in ambulatory care, and the importance of us having robust ambulatory care teaching environments, not just for our residents and not just for our faculty well-being, but also for the medical students who look to us for modeling aspirational ways that they may conduct themselves into their 30 or 40-year career in family medicine. And the data is out. When medical students experience their family medicine clerkships in high-performing teaching clinics, there's a much higher number that find out that indeed they can follow their heart's desire and have a meaningful and sustainable experience as a family physician going into the future. Important part of pipeline. Yes? Before we leave the slide, it's nice, this metaphor here of the double helix DNA that just calls out the importance of having high-performing clinical learning environments, i.e., think back to what the ACGME is asking for with its clear visits, and the teaching and academic missions. It's not an either-or, it is an and. Next. And what about the future beyond? Well, a few things for us to keep our eyes on. Certainly PCMH and its various iterations of transformed models of care, ambulatory and inpatient, are part of the future for us to understand. Look at the far right of those building blocks of high-performing primary care, and you'll see number 10 is a template of the future. Innovation, creating more value, understanding how to be ever more successful. That's a part of our future. On the left, you'll see the Family Medicine 4-year residency length of training project, borrowed from Oregon Health Sciences University Family Medicine Residency, which is one of the 20 programs across the country engaged in this pilot project. The initial data that's coming out of this is that there's high levels of resident satisfaction and fit with their long-term and short-term career goals. And likely, we will all be thinking about ways to make a 4th year an effective year in some way, whether it's required in our residencies or whether these are tracks for those interested residents to do makeshift fellowships. It will be interesting to see. But this is the environment and the dialogue that we'll be in as a discipline over these next few years. And it will behoove us as faculty to stay in tune and understand what our respective roles in propagating better ways of training are best done. Family medicine faculty milestones. We're going to end there. And this is a project that Society for Teachers in Family Medicine and those of us engaged in the faculty development aspects of STFM are in dialogue about. And we will see this probably this year at some of the presentations and some of the emerging publications by the Society for Teachers in Family Medicine. The idea being self-evident. What are the milestones? How do we actually measure ourselves as faculty? How do we establish our own individual and program gaps so that we can institute ways to teach, to improve ourselves, to meet the needs of our current and future learners? So family medicine faculty milestones. The future does hold us accountable in a great way. And I think every day when I get to come to work as a faculty member, I appreciate those who have come before. I appreciate those who I'm with now. And I think we all need to appreciate who we're becoming and who we'll be with in the future. I hope that this has been useful for all of you. There are many resources that are available. The CRN will be making those available as well. And I'm certainly available if Conrad and the rest of the CFP family have any need for us to pursue our future together. Thanks so much.
Thanks so much, Dr. Mills. That's such a wonderful perspective. I know I certainly have much greater appreciation for some of these future developments put in that historical perspective. I just wanted to add for our CRN members that if you found today's presentation useful, we've put in place a lot of different tools that you can use to continue the discussion. I just want to remind you that there is a listserv if you want to write to all of the other members of the CRN in a quick and easy way. All you have to do is email crn@familydocs.org. That's crn@familydocs.org, and it will go to all of the other CRN members who have signed up for that listserv. There's also a CRN internal site, CRN newsletter, and we do, of course, have in-person meetings at our Family Medicine Summit. We have a dinner at the Song Brown that coincides with the Song Brown funding meeting, and then we usually try to organize an event around the same time as PDW. And at each of these events, these are opportunities for us to drill down in more detail on ideas like this. So if you found today's presentation helpful and insightful, as I know I have, please don't ever hesitate to reach out to me. My email is camenta@familydocs.org, and I'd be happy to connect you with any other members of the CRN to gather resources for you or to include a discussion about this on future agendas. So with that, thanks again, Dr. Mills. This is so much appreciated, and I look forward to talking to you all soon.